Okay, let's get started again. Welcome back, everyone. For those of you who didn't meet me, so to speak, yesterday, my name's John Reed, and I'm the honor of being the chair of the Institute for Psychiatric Drug Withdrawal. And people say it's an honor to introduce people, but they don't always mean that. But today, actually, it is a genuine honor for me to introduce Dainius Pūras. I am a bit old to have heroes. But he is a hero of mine. We only met yesterday properly for the first time. Dainius is a psychiatrist at Vilnius University, which he was stressing yesterday is one of the oldest universities in Europe. But what he's become particularly well known for is his role as the United Nations Special Rapporteur on the Right to Health from 2014 to 2020, during which time he wrote some absolutely stunning reports on the state of mental health services around the world, emphasizing how the medical model and the drug companies had taken over from a more sensible, evidence-based psychosocial understanding of what causes human distress and what the solutions are. They're very, very powerful reports. My favorite saying from all of it is when he reminds us that we should not be focusing very much on chemical imbalances and be focused more on power imbalances. And I was very envious that I hadn't thought of that. It's a very, very wonderful phrase. So I'm going to hand over to Dainius. He's going to talk for 45 minutes. You'll have 15 minutes to ask him questions, and he's going to talk about how our mental health services deal with children and adolescents. So over to you, Dainius, and thank you so much for making the time to be with us. We're very, very happy to have you with us.
Thank you, John. It is a real pleasure for me to share with you my experience. I will try to put my slides. Okay. Can you see? No.
Yes, we can see it. That's great.
It's okay. Is it moving?
Yep.
Okay. So my experience comes from firstly national and regional or sub-regional experience. For many years, I have been working as a child adolescent psychiatrist and was involved in different policies when changes started in this Eastern Europe, more Eastern Central Europe. But then, as John told, I had this opportunity to see the global picture, and I used my mandate, my global mandate of Special Rapporteur on Right to Health, mainly for disclosing what happened with global mental health during last decades. And I think that it's important for us to reflect, before we move to children, to reflect the context in which mental health services are functioning. And in my reports, when I explored situation in all regions, because I was obsessed on my region or even sub-region, I was very disappointed by extreme medicalization of mental health issues in, let's say, former Soviet Union, but that was for different reasons. I will come back to this. But then when I explored situation in, let's say, Americas, in Western Europe, in Northern Europe, in Asia, Africa, and I visited also such countries like Fiji. So then I was confident to make my, let's say, diagnosis of global mental health in, let's say, strongest possible words, warning that we have gone wrong direction, even if that was made with a good intention. So instead of this very popular, message, global burden of diseases, which I think paves the way to further medicalization, I used message of global burden of obstacles. And these obstacles are overuse of biomedical model and interventions, power asymmetries, especially between psychiatrists and service users. So these asymmetries disempower people. And then biased use of evidence and knowledge, which may amount to corruption of knowledge. I mean, what medical students are still taught and what politicians and society at large is informed, or I should say misinformed about, all these chemical imbalances in the brain. So in my conclusion was that even when we achieve that more investments go to mental health field, which this not necessarily helps, because these investments may reinforce vicious cycle of discrimination, coercion, stigmatization, helplessness, and over-medicalization. And that after many decades of promises from biomedical paradigm, as we know, these promises have been very bold, there is no recognition, some sobering recognition of crisis of evidence and values. And from here, we come to a conclusion that we need change, and not cosmetic change, but very serious change on the level of moving to next paradigm. So some painful questions, for example, what messages should come from the centers, power centers, academic centers in global north to the global south and to the rest of the world? Again, about this to reach everyone, to close treatment gap by reach everyone who has some mental health condition, and what we do with this everyone. Shall we medicate them in Africa, in Asia? So this was the issues which I was raising. Of course, this also critical approach to biopsychosocial model, which seems like balance reached, but we know that in reality this bio is so powerful that it overshadows and disempowers the psychosocial. And the roots, when I was exploring the roots, I came to effects of the Cold War. I was on the other side of the Iron Curtain, let's say 40 years ago. I was dreaming about free world, which for us was, democracies. And many of you probably were dreaming about, how to get rid of capitalism, and maybe were dreaming about how nice is Soviet Union. So both sides were accusing then each other for violations of human rights. In both East and West, things went wrong, because selective approach to human rights always paved the way to dominance of reductionist biomedical approach, and I should say betrayal of human rights in the name of medicine, which was very painful for me as medical doctor. So, for example, in Soviet Union and satellites, a brutal form of biomedical model with extreme levels of institutionalization and medicating adults and children for political reasons, because Soviet Union was trying to show that they solved all the problems, mental health related, through defeating capitalism. And from there, we never had community services, we never had psychosocial interventions, we never had social workers. Well, in developed countries of Western world, you know more than me, and I agree with this, harmful effects of neoliberalism, inequalities, and poverty to mental health happened. And what was very interesting and for me many painful, when Berlin Wall fell and when Iron Curtain was over, we were dreaming about, consultants coming from the West and bringing helping us to get rid of very extreme biomedicalization. Instead, in the West, the era of Prozac started at that time, in the 80s, in the 80s. So after 50 years of Moscow telling that all problems can be only in the brain, now consultants from New York and London were coming and telling, oh, if you have epidemics of suicide and self-destructive behavior in Eastern Europe, so it also give Prozac to people, and Prozac solves all problem, whether it's mild case or severe case. And in this way, we experienced one more very strong wave of this biomedical reductionism. Well, as we all know, human rights-based approach is crucial to health, but especially to child mental health. So social and determinants of mental health are very important. All forms of violence, discrimination, and inequalities have negative impact to mental health. And what I was raising in my report, states need to invest in enabling non-discriminatory and non-violent environments in all settings, which is family, school, workplace, community, also healthcare, mental health care services should be without violence, and society at large. And all services to children and adolescents should be child-adolescent friendly. And families needs to be supported with a variety of community-based non-discriminatory services. So I don't want to stop on this because these are universal human rights principles, and especially it's important to human rights of the child. Right, that child has a right not only to life and survival, but to holistic development, which includes emotional and social development. And you cannot improve emotional and social development with medications. So again, when some comments about my subregion, and then I moved to global picture, this Soviet experiment was that when I was, let's say, young doctor, the numbers of institutionalized children were increasing with each year because, again, Soviet Union was hiding all possible social problems. They were telling we don't have them, and if a child has some broken home and his parents are drinking, and there were a lot of this, the explanation was that something happened with the brain. But if in adult psychiatry, it was this Moscow School of Schizophrenia, to diagnose all political dissidents. So in child adolescent mental health was more about organic. It was more hypothesis that something organic damage happened in brain, but we had no right to tell that something wrong was in psychosocial environment because of this ideology was not allowing this. So then in 70s, Communist Party declared that capitalism is defeated by socialism, and hence there should be no more psychosocial risk factors. To hide existence of such factors, very aggressive medicalization of any mental health related issue prevailed in theory and practice. So thanks to this very brutal theory, I became allergic in 80s already to biomedical model, but I have to confess that I was idealistic about what is happening in let's say, Western part of Europe or in US and so on. So, and the main methods in my region was long stay in psychiatric hospitals and residential institutions, high dosages, I should say very high dosages of psychotropic medication in all possible cases of mental and even developmental disorders. Autism in Soviet Union, all cases of child with autism were diagnosed as early onset schizophrenia with high levels of haloperidol prescribed for 3-year-old children and so on. Depression, of course, intellectual disability was managed with high levels, high dosages of psychotropic medications, and of course, challenging behavior in adolescence. I could see like my supervisors were diagnosing schizophrenia to adolescents who were punks because of their haircut. Such haircut means schizophrenia, and that's it. So this was my school, so to say, which I received. And no, we did not have teams of professionals, no community-based services, just only child adolescent psychiatrists with very biological training. And as doctors, they will prescribe medications, but sometimes also talk to parents, instruct in rational way that you must be good and children must be good. That's it. So also not only psychotropic medications, but diuretica were prescribed for behavior problems for children, because the idea was that if child is nervous, so we have to take away liquids, water from brain, so that there may be some pressure on brain from it. So we should prescribe diuretica. So now we move to global picture, and I should say what I did in reports. I was very critical to global mental health and not so critical to global child mental health, because from my contacts with international community, you know, there is YACAP, ESCAP, these are international and European child adolescent associations, and many leaders, many academic professors of child adolescent psychiatry were resisting as much as possible influence from Big Brother, means adult psychiatry, and from Big Pharma. Child adolescent psychiatry is not so much spoiled by these influences, and this is why it's weaker. This is why it's not powerful. So there's also this ambivalence in this professional group. Well, we are not so strong as adult psychiatry. Maybe we should move more biomedical way, then we would be more powerful. But yes, then we can have the problem what adult psychiatry has, which is human rights violations. So what was helpful is tradition in many countries to sustain child adolescent psychiatry, child adolescent mental health as a least biomedical specialty from all medical specialties. And I think this is strength of child adolescent psychiatry, because it's always reliant on teamwork and on spectrum of psychosocial interventions. But of course, there remains a very strong pressure during last decades to increase the role of biomedical interventions in the management of mental health conditions of child adolescent mental health field. And there are many incentives, formal and informal, for child psychiatry to become more biomedical. For example, there is fragile agreement, and we can read in textbooks that medications are not the first choice treatment. In mild and even in modern cases of depression, ADHD, and so on, psychosocial intervention should be provided, and only in severe cases. But you know what happens in practice. In practice, there is a lot of training in medical schools, as you know, that the doctor is the more aggressive, the more better is doctor. So if you're a doctor, why don't you prescribe medication? What happened with you? So this is why in practice, this recommendation is not observed. In my region, for example, my colleagues, they will prescribe very easily medications in mild cases of depression for adolescents and ADHD. And when you ask why, they tell you, no, you don't understand. You think that we will have all the psychosocial services as they have in the West. We will not have. And if a family comes, I have to offer something, I will offer medications. If even I know from textbook that there are no indications. So there are many examples of overuse of psychotropic medications in the cases of depression, ADHD, autism, anxiety disorders, eating disorders, and so on. This I borrowed from John Reed. Thank you, John. This is from his paper from 2021, and I think you know these numbers, these trends, like in Australia, you see I will not read them all, like 5 to 11-year-olds, more than 4% are on medications, mental health related medications, adolescents even more than 8%. Some European countries are catching up with the USA and Australia. In the UK, for example, 7% of adolescents were already using at least one psychotropic medication by 2004. Most commonly antidepressants. The number of children under 16 using stimulants to treat ADHD increased 34 times. So from 92 to 2013. And the number of UK children under 17 prescribed antidepressants increased by 26% just in 5 years, and so on. So I think that we are now moving to some sobering understanding that it has gone wrong, but too early to celebrate victory, of course. But we should use better, very powerful message coming from new research. That quality of brain, I put it more simple way, quality of brain as it appears now from brain research and functioning of body and quality of physical, mental, but also physical health are to large extent determined by quality of human relationships in early childhood. You know, toxic stress, adverse childhood experience have a huge impact not only on mental health, but to prevalence of chronic non-infectious diseases, because toxic stress, if not managed well, will produce for entire life ill reaction to each stress. And from here we have epidemics, not only poor mental health, but we have epidemics of chronic non-communicable diseases. So ironically, after many years and billions of dollars and euros spent on search of biomarkers in brain, it appears that social determinants are now very important in this eternal chicken and egg dilemma. So they were looking for hard evidence for biomarkers in the brain, and they found out that the quality of brain is determined by quality of human relationships, which cannot manage again with medications, I think so. Well, this is not new in medicine. A child-adolescent psychiatry should become a leader in the field of so-called new morbidities. You know, new morbidities, all these morbidities which are related with stress, with social determinants, with poverty, with violence, discrimination. So, and as you know, Rudolf Virchow was famous doctor, father of pathology, a very real doctor. He told more than 100 years ago, medicine is a social science. So if we dig deeper, this crisis is not only in psychiatry, this biomedical reductionism. It covers all medicine. Of course, in other fields, they find markers, yes? This is very different, like in oncology. They find marker and the biomedical treatment may be very effective, differently from mental health and psychiatry. But still, in the rest of medicine, not only in mental health, there is a lot of overuse of diagnostic and treatments which are biomedical and actually are excessive. So the reality remains that still a lot of incentives are in place for physicians and medical specialists to become as biomedical as possible. It can be by law, but usually it's by practice. It's informal. For example, a child-adolescent psychiatry, as I told already, he has a better reputation, not that much affected by corruption than general psychiatry, but not that powerful. And young doctors know it's better to go to adult psychiatry, not to child psychiatry. Also, many other ways of increasing the role of medication. Medical education, as I told, has chosen this very, very reductionistic way to explain to doctors, the future doctors, that medicine and psychiatry is about miracles. Just let's wait and somebody will invent gene of anorexia, gene of suicide, you know, and other nonsenses. The concept of comorbidity is very interesting for me. You know, comorbidity, that we can diagnose in psychiatry and child psychiatry to one person, we can make 3, 4, 5, 6 diagnoses. Yes, comorbidity, very modern approach. I think it's not such a good approach because it's used, misused again for over-medication. Well, I tell to my younger colleagues, why you prescribe medication in case of autism or you know, anorexia? You know that these conditions should not be managed by medication. Oh yes, they told, we know, but we found comorbidity. This autistic child is also hyperactive, so we can give medications, and they're so happy, you know. If doctor finds excuse, finds you know, argument to give medication, then he feels better, or she. So, and of course, a lot of power issues among medical and non-medical mental health professions. Yes, the doctors have one only difference to compare with psychologists. They can prescribe medications, and then they will use this opportunity. Also, power issues between general psychiatry and child psychiatry. Child psychiatry wants to be independent, wants to separate, but in many countries it is controlled by adult psychiatry. Even if these are separate specialties in many countries, you go to residency of general adult psychiatry or child psychiatry, but then you will see by law that adult psychiatrists have a right to treat children, but child psychiatrists, you have no right to treat adults, because of course adult psychiatry is better psychiatrist than child psychiatrist. Why? Oh, because, you know, adult diseases are more serious diseases and more biological. And again, you see these informal incentives. COVID, not only COVID, but all crises, they give, I think, for our side, more arguments to take initiative. Because all these crises, they show our part of truth. Like in COVID, many people became, adults and children became more anxious, yes? Shall we medicate normal reaction to abnormal situation? Of course, we need to give some support to these people who feel better, who became more anxious during, you know, peak of COVID, during quarantine. But why medications? What this has to do with medications? But as you know, in many countries, there was increased prescription again of medications. Now and as we know, in COVID, there was more violence against children, there was school closures, there was lack of socialization and relationship with peers for adolescents, which is a vital need for adolescents. And of course, their mental health deteriorates. And shall we move to medications to manage all these issues? And now in sub-region and in Europe, as we know, we have this very difficult situation of because of Russia, I should say, Moscow regime invasion, brutal military invasion in Ukraine. How many refugees, many children who are victims of this brutal attack. Shall we manage all this with medications? Well, possibly this is already happening, because again, doctors in my region will tell we do not have other options. What we can offer medications. And again, this vicious cycle may be reinforced. But what I want to tell that each crisis which happens, unfortunately it happens, but it gives more argument to our case, that let us stop medicating social, existential, psychological issues. These are not brain related issues. So mental health.
Dainius, you have five minutes left to leave.
Okay.
questions. Thank you.
Okay, so there are all, I'm moving to sort of recommendations that we should, interventions should target not just individuals and their brains, they should firstly target relationships and social determinants of health to reduce or eliminate violence, discrimination, inequalities. This is important to adults also, but even more to children. So why medications then? Avoid another wave of excessive pathologization and medicalization during the process of assessment and management. I like very much the new recommendation, like management of adolescent depression through watchful waiting. Mild cases can be managed through this, but some doctors will tell, what are you talking? Watchful waiting is not treatment. We are doctors. We have to take some active or even aggressive action. And this is, again, as I think, problem of medical education. So for conclusion, there was a UNICEF report quite good. I recommend, but it could be better. They talk again about mental disease, mental illness in children. You know, we should, you know, terminology is very, very important. If we tell mental illness, it already prompts, you know, opens the door for biomedical model. So maybe to conclude, human rights imperative is crucial, very powerful resolutions of UN Human Rights Council, 3 on mental health and human rights, more about adults, but can be used also to children and adolescents. Very good WHO guidance on community mental health services, not about children, but about rights-based approach, non-coercive services, and to address adversities in childhood and adolescence, of course. Prevent excessive medicalization of diversities, disabilities, mental health conditions, stop overuse of psychotropic medications in childhood and adolescence. Yes, this is devil in the detail. I don't know who can decide when it is overuse. And our opponents are very managing or manipulating this issue very well. They will always agree. They tell, yes, we should not overuse. But I think that my colleague will overuse it, and he or she tells, no, I give medications only in more severe cases. So this is very difficult to decide who is right and who is wrong. Mainstream mental health and discontinue investments in segregated psychiatric and so-called correctional institutions, prioritize psychosocial interventions, and of course therapeutic relationships. These are key, and replicate good practices, which we have a lot in the world that provide non-discriminatory, non-coercive mental health services and avoid biomedical reductionism. So I think still that biomedical model is not wrong per se, but quite often it is overused. This is the issue. And I am not ready to say, for example, that stop using psychotropic medications. Maybe, but I'm not ready. But when is this line when you already should use? Each doctor will decide himself, and there is a lot of space for manipulation. I think this is the issue. So thank you.
Thank you, Dainius. Covered so much material. That's fascinating. We have lots of questions and about 10 minutes, so I'll do my best to squeeze 2 or 3 in. One of the first questions was, do you think that safe tapering from psychiatric drugs is a human right? And I would just add to that, have you found any examples of your knowledge around the world of any services dedicated to helping children or adults withdraw from psychiatric drugs?
Well, I'm sorry to say that I had not enough time, and I don't think I'm expert in issues of withdrawal. I want to find more time for this, but I was so busy with the general issues of this to diagnose this context and to say that we have been on wrong way. That for me, this issue of withdrawal just symptom, is consequence of what happened. And of course, we should know more, for example, about drug withdrawal in children, but I am not ready to be expert in this field. I appreciate very much many of colleagues who are here also who know much more than me. My duty was to say, especially for me as a medical doctor, that this status quo, what happened in adult psychiatry and partly in child psychiatry, leads to systemic abuse of human rights, of child rights, and it cannot be so. It's not unacceptable. It cannot be so that these abuses are done in the name of medicine. So this is wrong.
Okay. There's another question here about prescribing antidepressants to adolescents who are feeling suicidal, and whether they are being told that it reduces suicide, when we actually know that antidepressants can increase suicidality in adolescents. I wonder if you'd like to comment on any of that.
What happened, for example, in my region, when this message was coming out that, about some antidepressants may provoke suicidal attempts, I remember how many colleagues, many child adolescent psychiatrists were irritated, and they were asking each other, so are we not allowed now to prescribe antidepressants? And my answer, for example, was that, well, you had to think 2 or 3 times before you decide to prescribe. Now you should think maybe 4 or 5 times, but this does not mean that you are not allowed. But then, they want instructions, yes or no. And I think it's about critical thinking. And also in many countries, like in my region, it's so that it's liability issue. If a doctor prescribes medication and something happens, like suicide, nobody will accuse him. But if he or she will not prescribe antidepressants and the suicide will happen, then this doctor will be in trouble. So this is a huge pressure to feel safe and to prescribe medications to sleep well for doctor. Because in many countries, it's very primitive understanding that the doctor's duty is to prescribe medications. And we have increasing number of evidence that if you manage a problem of depression and suicide only in biomedical way, like, medicating and hospitalizing, actually you increase the risk of suicides through sending message that these are hopeless and helpless cases. But in bureaucracy, this argument will not work. The audit in my region will look after tragic case if medications were prescribed. And also I want to add one thing. In my last report in 2020 to UN Human Rights Council, I took the next one more step, which was not welcomed by WHO, but I am proud that I did it. But it needs now some further discourse, because I critically addressed essential list of medicines. Because, essential list of medicines is holy things for government, and it has chapter on psychotropic drugs. And when I go to some country and ask, what about mental health in your country? So politicians will tell it's okay because we have essential medicines and patients can get it. So the trick from psychiatry was to convince politicians that psychotropic medications are life-saving medications. And I think it's wrong. So I recommended to remove psychotropic medications from the list of essential medicines. So can you imagine how negative was the reaction? But I don't think that I told too much.
here's another question for you, and this is perhaps the most important and hardest question of all. How do we put the power back into the hands of service users and take it away from the service providers? How do we do that?
Well, this is a process. I think it's happening, maybe too slowly. Very interesting question is that maybe in Global South it's easier than Global North, and we know why, because resistance was strong in Global North. And I suggest many avenues, not just one. There is some tension from experts like me with other side. I mean, I was criticized not only from psychiatrists, but also from human rights activists, because I did not fully support some like CRPD committee, which insists on banning all non-consensual measures now, you know? All governments ban all involuntary measures now. Good idea, but nobody's doing this. So I told, okay, if you are not ready for this, please invest as much as possible, not in this mainstream, you know, this status quo services, but in all these alternatives, which are many. In WHO, this guidance, there are 22 good practices where you can do things without medications, but they're under attack. Like in Norway now, free medication units, you know this, they are, I heard just, they are under attack now, maybe close them. So we have to push governments that these alternatives are not anti-psychiatry. This is hope to improve image and reputation of psychiatry, that it stops damaging lives of people. So this is a very serious issue. But yes, we are still, I don't think we're winning, but I never expected that after my reports, after 3-4 years after my reports, WHO in this guidance told many things the same what was told in my reports. So this gives hope, but still we have to do more, and we have to have critical mass. It's not yet there, but I am more optimistic than pessimistic, but it will take a long way, of course.
Of course. I'll find that guidance from the World Health Organization. I'll put it in the chat.
Yeah.
Hugely important. One more question. There's quite a few people in the chat saying that they have their parents of children who are in the mental health system, who are basically just getting medication and nothing else. Do you have any advice to them as to how they can negotiate with the system, with the psychiatrists, to help get their children either some better help or to get them out of the system? What advice do you have for parents who are caught, whose children are caught in the mental health system and being medicated?
You mean parents who have mental health issues?
No, parents who have, sorry, I wasn't very clear. Parents with children, parents who have children in the mental health system who are, and the parents are unhappy with how the children are being treated because they're only getting medication.
Well, this is, I don't know what to recommend. I am fan of democracy. I think that we are happy in those countries where we have democracy and where we can use everything, all measures which are allowed, which do not violate constitution. So just I noticed that there are not so many powerful national associations of parents. There are some fractions, yes, there are some splits, and then it's very easy for bureaucracies to manipulate. It should be national, strong, powerful associations of parents who insist on change, and that rights of the what was done in many countries by parents who have children with intellectual disability, for example. So the same should be for for each mental health condition, one of the problems is that some parents want medications. So what, it's easier way. So, and again, in democracy, we cannot, we have to be ready to have diversity of views.
Okay. Thank you. So the very last question, we have 1 minute left, and I'm going to ask, as the chair of the Institute, I'm going to be naughty and ask you for some advice. So with all of your knowledge and experience, what advice would you give to us as an institute as for the best things we could do over the next 5 years? What would make us most useful, do you think?
Maybe to try to have more coalitions, to have more broader movement. Of course, to go this to continue with this very important issue like withdrawal, but when needed, to make some pressure to make broader coalitions with many good, especially regional. There are many good regional associations, for example, of users and ex-users of mental health services. They have been my most powerful supporters and defending my position against attacks from, interest groups in Asia, in Africa, in Europe, of course, very powerful organizations of users, ex-users, survivors. So sometimes we need more broader coalitions when we want to make more pressure.
Okay, thank you. I think that's very wise. Thank you for that advice. And thank you for spending time with us today, Dainius, and for all the work that you've been doing. You probably inspire more people than you are aware of around the world. And so thank you so much.
Thank you very much. It was a pleasure, and hope to be in touch with you. Thank you.
Okay, thank you. Thank you, everybody, for your questions. Sorry I didn't get to all of them. We've got another 15-minute break now, and we're coming back at 15 minutes past the hour for our last panel discussion. So see you all in 15 minutes.